So this morning we're joined by Rolinda McFadden and Kim Miller. Rolinda is the quality specialist with AFMC's physician office team, and she'll be addressing some of the information specific to PQRS. And Kim will be, Kim is one of our implementation specialists here with AFMC's HITArkansas team, and she'll address some information specific to clinical quality measures. Before we get started, I'll go ahead and open up a couple of polls here just to get some of your feedback. You should see a screen here in just a moment. All right. All right. We'll give everybody a moment to answer the poll here. Are you currently participating in PQRS? Just a couple more seconds here. Okay, great. We'll go ahead and close this question. And it looks like about 67% of you are participating in PQRS. That's great. Okay, the next question, if you're currently participating in the 2013 PQRS, how will you submit your data? You should see that in just a moment on your screen too. Give everybody just a little bit more time. Okay. All right, I think we may have everybody there. Oh, maybe not. A couple more of you. That's great. All right, just a couple more seconds. All right, we'll go ahead and share this. This is interesting. Everybody can see. Several people using claims and EHR systems. And we'll go ahead and open up one more poll question. Have you earned PQRS incentives in the past? Okay, give everybody just a little bit more time. Looks like more than half of you so far have. Okay. We'll just go ahead and quickly share those results too. All right. Well, with that done now, I will go ahead and turn it over to Rolinda.
Good afternoon. Start with what is PQRS? The Physician Quality Reporting System, PQRS, is a reporting program that uses a combination of incentive payments and payment adjustments to report quality information by eligible professionals. The program provides an incentive payment to practices with eligible professionals identified on claims by their individual National Provider Identification Number, NPI, and tax ID numbers. Those who satisfactorily report data on quality measures for covered physician fee schedule services furnished to Medicare Part B fee-for-service beneficiaries, including Railroad Retirement Board and Medicare secondary payers. Beginning in 2015, the program also applies a payment adjustment to eligible professionals who do not satisfactorily report data on quality measures for covered professional services. The incentives would pay to eligible professionals who satisfactorily report data on quality measures for covered physician fee schedule services for your Medicare Part B fee-for-service beneficiaries, eligible professionals who do not satisfactorily report in 2013 can earn a 1.5% payment adjustment or penalty, which will be applied in 2015. Currently, there are 259 clinical quality measures available for reporting. These represent more than 30 specialties. 241 are available for claims and registry reporting. 51 are measures that are available for reporting through qualified EHRs. And there are 22 measure groups associated with these. The Medicare Improvement for Patients and Providers Act of 2008, MIPA, will require CMS to post the names of eligible professionals and group practices who satisfactorily report under PQRS. This information, along with additional measure performance information, will be posted on the Medicare Physician Compare website. So where did PQRS evolve from? A quick history of PQRS. PQRS began in 2006 as a 3-month pilot project called the Physician Voluntary Reporting Program, PVRP. It's a run-on of acronyms, so hang on for just a second. PVRP consisted of 16 clinical quality measures. Now, as you can see in the graph on the right, this has gone through several name changes and significant increase in the number of clinical quality measures available for reporting. Along the way, though, there have been 2 supporting programs, Doctor's Office Quality Information Technology, DOCIT, which focused on individual measures, and the Medicare Management Performance Demonstration, MCMP, which Arkansas was one of 4 pilot states across the United States that was participating in this program. This was a 3-year incentive program that Arkansas physicians were invited to participate in, and this program proved to be a catalyst for many early adopter physicians. One piece of information that I would like to note right here regarding e-prescribing is that if you have not successfully reported your e-prescribing measures for 2012, you have until June the 30th of 2013 to submit 10 claim forms with the G8553 code to avoid the 2014 penalty. To avoid the 2015 penalty, please make sure that you meet the e-prescribing incentive guidelines by reporting a minimum of 50 e-prescribing events, or were achieve meaningful use under the Medicare or Medicaid EHR incentive program during 2012 or during the first 6 months of this year. Who is impacted by PQRS and the penalties associated? Under the PQRS, covered physician services that are paid based on Medicare physician fee schedules, to the extent that eligible professionals are providing services which get paid under or based on provider fee schedules, those services are eligible for PQRS incentive payments and or payment adjustments. Some professionals may be eligible to participate for their specialty, but due to billing methods may not be able to participate. Professionals who provide Part B services but bill Medicare at a facility or institutional Part A level would be included in that. Professionals who do not bill Medicare at an individual NPI level, where the rendering provider's NPI is entered on the CMS 1500 type paper or electronic claim billing associated with the specific line item services. And professionals who resign benefits to critical access hospitals that bill outpatient services at a facility level, such as critical access hospital method 2 billing, cannot participate since critical access hospitals do not include the individual provider NPI on their institutional FI claims. Services payable under fee schedules or methodologies other than the PFS are not included in PQRS. For example, services provided in federally qualified health centers, independent diagnostic testing facilities, independent laboratories, hospitals including Method 1 critical access hospitals, rural health clinics, ambulance providers, and ambulatory surgery center facilities are excluded. So as you can see, this list of eligible professionals is significantly larger than the list of eligible professionals has been in the past. please make sure and take note of the additions to this. Now, at this point, I'm sure you're wondering what this has to do with meaningful use in the clinical quality measures. Kim's going to give you an overview of what the CQMs are and what their requirements are.
Hello. I'm briefly going to touch on CQMs, or clinical quality measures, and then as we move forward, you'll kind of see how all this aligns and goes together. CQMs, or clinical quality measures, are tools that assist in monitoring and measuring outcomes. Clinical quality measures are tools that help us measure and track the quality of healthcare services. The CQM measures many aspects of patient care, including health outcomes, clinical processes, patient safety, care coordination, population and public health, and clinical guidelines. Currently, with CQMs, in 2013, as you all are probably well aware, EPs will continue to report from the 44 measures that were finalized for Stage 1. So basically, you're reporting a total of 6 measures, 3 being your core clinical quality measures, or for the slash there, if you have a zero denominator, an alternate core to replace a core, or 3 additional clinical quality measures. And then as we move forward in the future, EPs, now as you can see on the slide, we're talking about 2014 and beyond. But I wanted to go ahead and kind of touch on this, give you an idea of where we're going to be moving towards next year, so you'll all kind of be prepared as you're looking at PQRS and deciding how you want to move forward with this. I want you to know where you're going to be with your clinical quality measures. EPs are going to be required to report on 9 of the 64 approved clinical quality measures. The clinical quality measures must be selected from at least 3 of the 6 key healthcare policy domains. And the domains, as you see on your slide, are patient and family engagement, patient safety, care coordination, population and public health, efficient use of healthcare resources, clinical processes, and effectiveness. Also, I want you to take note, and this is going to be key as you move forward, beginning in 2014, all EPs beyond their first year of meaningful use will be required to report their CQM data electronically from their 2014 certified EHR system. So as we move forward beginning in 2014, as you can tell, this is going to change for providers. EHR technology that has been certified to the 2014 standards and capabilities will contain new CQM criteria, and eligible professionals will report using the new 2014 criteria regardless of whether they are participating in Stage 1 or Stage 2 of the Medicare and Medicaid Electronic Health Record Incentive Programs. Although clinical quality measure reporting has been removed as a core objective, all providers are required to report on CQMs in order to demonstrate meaningful use. Okay, and with that, I'm going to turn it back over to Rolinda and kind of move forward. We're going to look at some different incentives, basically kind of all the CMS incentives and how they all tie together.
So when we're talking about aligning CMS incentive programs and other programs that are out there, what you see here is meaningful use, PQRS, and the e-prescribing incentive program. With meaningful use, you can actually earn the PQRS incentive along with meaningful use. You cannot earn an e-prescribing incentive with the Medicare meaningful use, but you can with the Medicaid meaningful use. For PQRS, obviously, meaningful use, and it just goes down through to describe each of the programs themselves and how they relate to the others. The one thing that I will say in addition here is that Arkansas is involved in the Comprehensive Primary Care Initiative, CPCI. As this continues to evolve, we will include this information as well so that it reflects on this document because of the clinical quality measures or electronic measures that will be required to report through this program. Timelines, incentives, and penalties. The timelines for PQRS submission for 2013 are January 1st through December 31st. So claims must be processed by late February of 2014. Electronic submission, either by EHR or data submission vendor, has to be completed by late February. In 2013, you have the capability to earn a 0.5% incentive, but if you do not satisfactorily report for PQRS, you could face a 1.5% penalty in 2015. Successful submission for 2013 can be achieved several ways. Claims, qualified CMS registry or qualified EHR, data submission vendor, or direct EHR. Claims reporting involves a practice or an eligible professional reporting on a minimum of 3 unique measures for at least 50% of your applicable Medicare Part B fee-for-service patients, or the reporting of 1 measure group for 20 applicable Medicare Part B fee-for-service patients. Examples would be diabetes, ischemic vascular disease, hypertension, preventive care. Simply reporting quality data codes associated with the measures of your choice on the Medicare Part B claim. QDCs or quality data codes must be submitted with a line item charge of either 0 or 1 cent at the time the associated covered service is performed. Please contact your clearinghouse to determine which charge is acceptable. What we have found in the past is that clearinghouses may actually scrub the 0 charge, but please contact your clearinghouse so that you know how they accept this. The catch to the claims submission is that someone has to monitor the remittance advices or the explanation of benefit. The remittance advice or EOB denial code of N365 is your indication that the PQRS codes were received into the National Claims History. N365 reads that this procedure code is not payable. It is for reporting information purposes only. The N365 denial code is just an indicator that the QDC codes were received. It does not guarantee the QDC code was correct or that an incentive quota was met. However, when a QDC is reported satisfactorily by an individual EP, the N365 can indicate that the claim will be used for calculating incentive eligibility. For registry reporting, 3 measures as for your claims for 80% of your Medicare Part B fee-for-service patients, or 1 measure group for 20 applicable Medicare Part B fee-for-service patients. Please note that measures for either claims or registry with a 0 performance rate will be considered in the analysis, but will not be considered satisfactorily reporting for incentive eligibility. So what's a registry? Generally, it's a third-party vendor product that captures and stores clinically related data, calculates PQRS measures, and submits the PQRS or e-prescribing data on behalf of the provider. Methods of registry data collection include manual data abstraction, copying claims, web portal practice management software, which does data mining, your EHR combination, EHR-based reporting. Under the EHR-based reporting for submission, there are 2 options, direct EHR or data submission vendor. With either one of these, there are 2 options that will successfully report for you. Option 1, which aligns with meaningful use in the clinical quality measures. You would report on all 3 PQRS EHR measures that are also Medicare EHR Incentive Program core measures. If the denominator for 1 or more of the Medicare EHR Incentive Program core measures is 0, report on up to 3 PQRS measures that are also Medicare EHR Incentive alternate core measures, and report on 3 additional PQRS EHR measures that are also measures available for the Medicare EHR Incentive Program. Option 2, which would be to report at least 3 individual measures and report each of these measures for at least 80% of your eligible professionals' Medicare Part B fee-for-service patients during the reporting period to which the measures apply. Please note that any of the above reporting methods with a 0 performance rate will not be counted for either data submission vendor or direct EHR. For 2013, vendor products must be PQRS qualified EHRs or data submission vendors, and for 2014, vendor products must be certified by the Office of the National Coordinator as CEHRT certified. Direct EHR submission of PQRS quality measure data is completed directly from your EHR. Data submission vendors submit PQRS quality measure data extracted from your EHR to a qualified EHR data submission vendor. This vendor would then submit the PQRS measure data to CMS in a CMS specified format on the EP's behalf. Currently, there are 55 vendor products recognized as data submission vendors. Some of these we more frequently see in Arkansas would include Allscripts, eClinicalWorks, Success EHS, Athena Health, Cerner, GE Healthcare, Greenway, Health Fusion, and MIE. Please note that several of these may have costs associated with them and may require additional modules or software. The 2013 direct EHR vendors. Currently, there are 24 recognized vendors. Some of these include EMDs, Vitera, Success EHS, Health Fusion, Epic, and Aprima. Both HITArkansas and the physician office team work closely with several of these vendors to produce successful PQRS submissions for 2012, and we're looking forward to this same success in 2013. So in order to earn the 0.5% incentive, EPs must satisfactorily report for the method chosen. 2013 begins the penalty aspect of PQRS. EPs who do not participate in 2013 will receive a 1.5% PQRS payment penalty beginning in 2015. Be aware of those included in the list of eligible professionals. The bottom line, what you really want to know now is probably just how to avoid the penalty. To avoid the 2015 payment adjustment or penalty, a provider needs to successfully report one claim on one applicable measure. However, CMS strongly encourages EPs to report on as many applicable patients as possible. They include this criteria in 2013 for avoiding the 2015 payment adjustment as an attempt to help EPs during the first year of reporting. You should also be aware that eligible professionals working for more than one organization need to meet the reporting criteria for each tax ID number where the EP works during the 2013 PQRS program year to avoid the 2015 PQRS payment adjustment for each tax ID number. This also is the same criteria for e-prescribing. So if you have physicians working under multiple tax ID numbers, they must meet this criteria for both tax ID numbers. This example on the screen here will be available shortly on the website. It is a cut and dry, no holds barred, quick way to address the penalty and potentially avoid it. Go back one slide for me. What you need to be aware of in avoiding the penalty, though, is that under Section 3007 of the Affordable Care Act mandated that by 2015, CMS began applying a value modifier under the Medicare Physician Fee Schedule, MPFS. Both cost and quality data are to be included in the calculation of payments for physicians. You'll see this listed as the value-based modifier payment, or value-based payment modifier. In 2015, physicians in groups of 100 or more eligible professionals who submit claims to Medicare under a single tax ID number will be subject to a value modifier based on their performance in calendar year 2013. These groups with 100 or greater eligible professionals under their tax ID number must self-nominate to group report between July and October 15th of this year. They must also choose one of 3 PQRS group reporting methods, either web interface for group reporting option, a registry, or request that CMS calculate the group's performance on quality measures for administrative claims in order to avoid an additional 1% value modifier adjustment to the 2015 payment under the physician pay fee schedule. Self-nominating, registering for, and then participating in 2013 will result in a 2015 value modifier of 0. There would be no economic impact on 2015 payments. We will provide you with additional details regarding BBMP after this webinar. So next steps, what you have to do. Determine the method of submission, or if you're just trying to avoid the penalty. So are you going to submit by claims? Do you prefer to submit by registry or EHR data submission vendor? Or is your goal just to avoid the penalty? From this point, if you are looking for the incentive, you need to choose your measures. We highly suggest that you think about the clinical quality measures you are currently submitting data on for meaningful use. These measures, some examples are listed below. NQF 28, which is your core tobacco measure, is PQRS measure 226. NQF 13 is PQRS 237, and it's the core hypertension measurement measure. This measure is only available for reporting through EHR or data submission vendor. NQF 421 is PQRS 128, and this is your core BMI. You're already beginning to capture some data regarding these measures. So in looking at what needs to happen as you move forward, think about aligning. We certainly are.
All right. Well, before we wrap up the rest of our presentation, we'll go ahead and open up a couple more poll questions before we get to your questions. So right now, you should be able to see on your screen in just a moment anyway, our last 2 poll questions, the first of which is, do you plan to participate in PQRS for an incentive in 2013? And we'll give you just a moment to answer that. Seems like most of you are. Okay. Go ahead and close that down and share it for your benefit. And then our last poll question is, do you plan to participate in PQRS to avoid the penalty in 2013? And you should see that here in just a moment on your screen. Okay. We'll give you just a few more moments here. All right. All right. So over 90% of you said yes. That's great. All right. Well, now we'll go ahead and open it up and see if anybody has submitted any questions to the chat feature here, or if anybody has raised their hand. So we'll go to the questions that have been typed in first. Let's see. Lots of them. That's great. First question is, what if the CRNA/anesthesiologist provides services as an independent contractor to a hospital? The hospital bills a facility charge, and the CRNA/anesthesiologist bill professional services to Part B. Are they eligible for PQRS benefits? That's a good question. While we're looking for that question, we'll go on to the answer to that question. We'll go ahead and see if we can answer another here. Oh, Rolinda has an answer here.
If the CRNA or anesthesiologist provides Part B services but bills a Medicare at the facility or institutional Part A level, then no, you're not eligible. So please clarify hospital bills to facility charge. So at this point, no, but we will clarify that just to make sure. If you will provide Jen with your contact information.
Mm-hmm. And you are more than welcome to contact us after the presentation as well. We'll have some contact information up here in just a moment. And you can certainly submit questions that way too. For now, okay. Next question is, so if it's already June, is it too late to start for this year?
No, it's not. The question is, though, are you looking to start to avoid the penalty or to earn an incentive? If you're looking to earn an incentive, the suggestion that we would offer would be either contact your EHR vendor to see what options they have available, or contact us for a registry product that may have been used in our state successfully in the past. With the registry products, those do not have to be submitted until after January 1 of 2014.
Okay. All right, the next question is this information available to print? And the answer is yes. We'll have it up on both the AFMC and the HITaRkansas website sometime early next week, at least on the HITaRkansas site, under the Resources tab. There should be a section about webinars and handouts, and you'll find that information there. Next question is, where can we get slides of this presentation? Same answer. Good question. Next question is, let's see, so if we are billing for nursing services under the nurse's NPI, then we would need to submit PQRS for them? Question mark?
That is correct.
Okay. Can you show the list of EPs again is the next question. And yes, we can. Let's go back to that really quickly. Slide 4. There we are. And again, we'll have these up on the website so you can reference them later. If you aren't able to commit all of this to memory right now, that's just fine. Next question. Are you still penalized for PQRS if you aren't signed up for PQRS?
Yes, you are. If you bill Medicare claims, then your name is already out there. So PQRS, you do not have to sign up for it. It is voluntary, but if you do not voluntarily submit, you will earn a penalty.
Okay. Next question is, can the G8427 be added at time of billing, or will it need to also be in the medical record? Another great question.
Penalty.
We're conferring here.
Yeah. G8427 needs to be added at the time that the claim is billed.
Okay.
If you are following the guidelines as set forth through this measure itself, the measure itself is patients 18 and older on the date of the encounter where your current medications were documented. You are attesting to documenting a list of current medications to the best of his or her knowledge and ability. This medication list must include all prescriptions, over-the-counter medications, herbal supplements, vitamins, minerals, dietary supplements, and must contain medication name, dosage, frequency, and route of administration. EPs reporting this measure may document medication information received from the patient, an authorized representative, or a caregiver, or other available healthcare resource. So after that has been attested to within your EHR, much to medication reconciliation for meaningful use, you would report the G8427 on your Medicare claim.
And I'm going to touch base on this too. This is Kim. For that measure, like what she's saying, just realize that by using that G8427, truly kind of as we reiterate with the core measure of active medication list, you have to have all this documented, and this is kind of where you can start to see the crossover and the alignment of these measures as we move forward, that you are attesting that all prescriptions have been reviewed. You know, this isn't about, you know, clicking the button of review. I mean, you truly have to have that documentation in there, all reviewed, over the counter, or herbal supplements, and then you report that G8427. And also, you know, this goes along with meaningful use with your core measure, you know, review active medication list. So just remember, you know, we want to make sure that, so what I wanted to kind of add to that when you say does it need to be documented in the medical record, yes, your documentation needs to be tight, because as we submit this and get the remittance, the EOB back with we have to have that documentation in place, you know, to show that you did submit these codes and this is what you submitted it for. And as Rolinda said, we'll have this resource available. I know that was a lot of information to try to write down as we're going through, so this will be a resource that we'll have available soon.
Just remember, though, when you report that on the claim, that you still have to monitor your EOBs and RAs for that denial code. That is the key that tells whether or not this successfully went through. So make sure that you are aware of that.
We're going to go to the phones now. Looks like Marie has a question. Marie, we're going to unmute your line, and can you hear us? All right, we can hear you as well. Go ahead and ask your question.
And I'll tell you, I think it was like 3 pounds.
Hey, Marie, this is Jennifer. Can you hear us? Your line has been unmuted, and you're welcome to answer your or ask your question.
Whoops, we accidentally.
Oh, okay, no problem. See if anybody else has a question here that would like to ask directly to our presenters. And again, if you do have a question and want us to open up your phone line, you can go ahead and raise your hand there. Otherwise, we will go back to our question pane. Let's see. All right, the next question that we have submitted online is PQR reporting period a year or 3 months? Good question.
PQRS reporting for 2013 is a 1-year time frame, January the 1st through December the 31st.
Okay. Next question is, where can we find this online to print out? Again, this will be up on the AFMC and the HITArkansas website here early next week. All right, the next question is a good one. It says, all UAMS departments, clinics, and other services are under one TIN. How will those be reconciled?
The way that they are going to be reconciled is through CMS will evaluate the tax ID number and look at the number of eligible professionals included under that tax ID number with reporting NPI numbers. So with that being said, if you have multiple eligible professionals who bill fee-for-service Medicare under their own tax ID number, and that puts you at or above your 100 threshold, then you need to look at the group reporting option, which we can happily discuss with you offline if you'll provide us with your contact information.
Okay, let's see if anybody else has any questions out there. Next one. Does any of this pertain to pediatrics and Medicaid claims?
No, PQRS is specifically Medicare, but if you see any Medicaid or Medicare patients, primary or secondary, then you could potentially be assessed a penalty.
And I'll further that, because this is a question Rolinda and I have discussed. It's been asked before. Just remember, kind of like e-prescribing, once these penalties are applied, they are there. So you may just kind of look at, you may check your primaries, your secondaries, make sure that you do not have any of that population, because once these are applied after this year, then those penalties are there. So.
Okay. Looks like we have one last question in here I can see. What are the, and there may be more here, that's fine. What are the number of measures and the percentage of patients required for PQRS reporting for small clinics, say 4 EPs? If we meet meaningful use, do we need to be concerned with adding the G codes to all claims?
Yes, you do. PQRS, in relation to meaningful use, is a separate program. The alignment comes in with the measures themselves. The measures align. So when we're talking about, for example, the hypertension management measure, which is NQF 13, yes, we are looking at that measure for both programs. When you report for PQRS, you have to report 3 measures at least. Depending upon how you decide to report, whether it is claims, registry, EHR, data submission vendor, that would determine the threshold that you would have to meet in order to earn an incentive.
So the answer to that question is no. I mean, if you meet meaningful use, you do still have to submit. I know that is confusing, and as we move forward, we hope more alignment, comes into play. But the only thing currently would be the e-prescribing, and then if there is an option and you just need to talk with your reps as they come to see you, there is a pilot program available, but right now we haven't had anybody participating in that. So you do have to submit these measures separately, but you just need to start looking at how they overlap and align.
Okay. Oh, we have more questions coming in. This is very good. Next question is, we have a physician that only works 1 day a week at our clinic. Are we required to report PQRS for them?
Yes, in order to avoid the penalty. You do not have to report to earn an incentive, but you should still, it is highly recommended that you report to avoid the penalty.
Okay. Next question is, what happens if you are an OBGYN practice with limited Medicare? How many claims per physician do you need to submit with the G8553? 2 of the physicians have met meaningful use. The other 2 have attested but not been approved yet.
Okay, G8553 is specifically related to e-prescribing. So with even a limited Medicare practice, you would still need to report the appropriate number of G8553 e-prescribing codes. However, you do state that you have one that's met, looks like all of them have attested.
2 have attested.
As long as they attested during the year of 2012 or during the first 6 months of 2013, you should be exempt from the e-prescribing penalty for 2014. However, 2013 continues on after this first 6 months through the end of the year to avoid the 2015 penalty. So make sure that you continue to monitor your meaningful use so that you can meet that exemption again come the first of next year.
Okay, next question. Excuse me, if you report for 2013 and we only started with claims recently, should we be going about reporting by registry?
For claim submission, it is 50% of your Medicare population. So if you can hit 100% of your Medicare population from now to the end of the year, then absolutely, that would probably be the most feasible way for you to meet it right now because you've got the measures in place to meet the 3 measures per provider. Now, should you consider alternative reporting options such as a registry? You would complete that information after the end of this year.
Okay. Let's go to the next. We have several questions here. Can the G8553 and the G8427 code be put on the same claim?
Absolutely. And I would highly recommend it because if you're putting one code on there, go ahead and include the other one, assuming that you have attested to and completely documented that you reconcile the medication.
All right. Next question. So if someone has met meaningful use, they still need to submit claims with G8553?
No. if they met meaningful use for January 1, 2012 through December 31st, 2012, or January 1, 2013 through June the 30th, 2013, they hit the exemption for the 2014 penalty.
Okay. Next question. What is the minimum Medicare patients that the physicians need to have to be exempt?
Minimum Medicare patients for the penalty exemption is simply reporting one measure on one Medicare Part B claim one time and receiving your N365 denial code. However, it is highly recommended that you submit additional measures or additional G8427 codes in order to assure that you are not going to receive a penalty.
Okay. Next question. We submitted PQRS data for 2012 through a registry. If we want to avoid the penalty for 2013, can we use report G8427 this year to avoid the 2015 penalty?
Yes, you can use the G8427 if you're not going to go ahead and report by registry again this year. If you are reporting by registry this year and you feel that you will meet your threshold, then you do not have to report the claim.
Okay. I have a few more. If we submit e-prescribed G8553 on every claim, what else do we need to submit?
You don't need to submit anything else, but I would highly recommend that you go back and evaluate your RAs and EOBs, because we ran into situations in prior years where these were going through. They were being submitted, but they did not follow through and look for the denial codes on the remits and were faced with a penalty. So please, I cannot express the importance of this enough.
Next question is, what registry do you use if you do not want to submit claims for e-prescribing?
There are several registries available out there. If you will talk to us offline, we can provide you with a couple that have been used successfully in prior years.
Okay. Next is there a minimum number of Medicare patients to be exempt from e-prescribing?
No, the minimum is related to submitting at least 10 e-prescription G8553 codes before June the 30th and 50 before the end of the year to avoid future penalties. However, if you or your practice has met meaningful use for 2012 or will meet meaningful use during the first 6 months of 2013, you will be exempt.
Next question is, how many claims per provider do you need to send on the G8553?
The G8553 for 2012, which continues into the first 6 months of this year, you will need to submit 10 per eligible professional. For the whole year of 2013, which reflects on the 2015 penalty, it is 50. Again, unless you've met meaningful use for 2012 or during the first 6 months of this year. However, if you had nurse practitioners or other eligible professionals who were not able to meet it, then yes, you need to submit the claim.
All right. 7. Are we required to reconcile the medications that each patient encounter?
Yes. And this would go right along with your meaningful use core measure for medication reconciliation. For your medication list. Current documentation of current medication, to the best of your knowledge, that all prescriptions, over-the-counters, herbal, and vitamins, minerals, and dietary supplements must contain medication name, dosage, frequency, route. And this was received from the patient, an authorized representative, or a caregiver.
Okay. And it looks like the last question that we have here are, what if the physician is new, has not attested, and has a limited Medicare practice? How do we avoid the penalty? She may not have 10 Medicare patients. She started in August of 2011.
Has she signed up with the intent to participate in meaningful use? If she has signed up and registered to participate in meaningful use, then this could potentially avoid the penalty for her also. And we'd be happy to talk with you in further detail about this particular provider offline.
Go ahead and put up some contact information there so you can reference that. Okay, now the last question. If we have already met meaningful use, are we exempt from the 2015 penalty?
No. For PQRS, this does not exempt you from the 2015 penalty. You would still need to submit PQRS quality measures for this year, or at least enough to avoid the penalty.
And this is Kim. The exemption that we've been referring to is for e-prescribing. That if you have met meaningful use, then that is an exemption for e-prescribing, but not for PQRS.
Okay. Looks like we have about 8 minutes left. I will stop saying last question because they keep popping up, which is wonderful. We love questions. Let's see. Question is, all APNs in our clinic have been, let's see, let's get to there first. Okay, the question reads, all APNs in our clinic have been incident to therefore no billing under their NPI. If they start collaborative in 2014, do they start MU or meaningful use? I think we may need a little clarification.
We might need a little, yeah, I'm unsure if they, could you give us a little more detail? So I understand, okay. So currently, if you could give us a little more detail on the billing on that question, we'll be happy to answer it.
Or if you'd like to raise your hand,
yes,
we'll open your line and talk with you about it right now. Ben. All right, Ben, let's see if we can open up your line here. Then we just sent you an audio pin, so if you enter that, if you're able to talk with us on the phone right now. And if not, again, you've got the contact information right there, so you can certainly call either Kim or Relinda, and they'd be happy to answer your question. Okay. The next question is, can you use G8427 to avoid the 2015 penalty and also submit data through registry to earn incentive for 2013?
Absolutely. Matter of fact, this is one of the things that we recommend for those who may have some questionable submissions as to whether or not they will meet the thresholds for the 80% reporting for the registry. It is absolutely acceptable to go ahead and submit the claim for the single measure on one Medicare Part B claim one time and receive the N365 denial code to avoid the penalty. But I would suggest that you submit more than one.
Okay. And it looks like Ben is available now, so we'll unmute your line. Ben?
Yes. Can you hear me?
Yes. Mm-hmm.
Our APNs submit Incident 2 billing. In other words, so they the billing physician, they go under a billing physician, but there's a rendering. So all the billing goes under the physician. It starts the progress note or the service, and then they carry on Incident 2 to that. We're going to start collaborative billing, which they will be just billing themselves. That they actually be billing under their MPI number at that point in time. So will they need to start reporting meaningful use and the PQRSs, or we haven't done it so far on collaborative. So do they actually start this process like they're brand new?
Okay, on the Incident 2 billing, if they are billing right now and it's actually billing under the collaborative physician,
yes,
and so their NPI number is not showing up as the rendering, correct?
That's right.
So no, they will not be impacted by the penalty at this point.
Okay.
But when they begin to bill and their NPI number is associated with that line item, yes, they will be.
They will be penalized, or they will have to start?
They would need to start because they could potentially earn the penalty.
Yeah. So once they go collaborative, then we need to start Meaningful Use and the PQRS.
Now, for meaningful use, the nurse practitioners can only test for meaningful use under the Medicaid program.
Okay.
So
Yes.
that would not change if they do not have the Medicaid volume. If you're under, just doing the Medicare and EHR incentive program, there is not, an avenue for nurse practitioners to attest under the Medicare. But if they have the 30% volume for Medicaid, then yes, then you can.
Did I understand you, just an additional question, did I understand you say that went from 10 for June 30th and to 50 by December 31st on the e-prescribed?
Say that one more time.
You said they have to have 10 e-prescribes by June 30th, and you say 50 by December 31st?
Yes, I did.
Yeah, last year it was 25. Is that correct?
That is correct.
Okay,
What?
so they did change it for this year. Wow, that's a big step.
It is. It's a huge step. It's a huge step. And, we expect that, as you saw in one of the first slides, that the number of clinical quality measures since 2006 has gone from 16 to 259. We expect these thresholds to continue to increase and evolve.
Yeah.
What I would suggest is, since they are not billing, because they have prescriptive authority, they
you can't really get around that. And unless they, the exemption, like you said, they're not doing meaningful use, so that doesn't really leave an avenue.
Right. So when they start collaborative, then that's when I have to start doing keeping up with the e-prescribes also.
Okay, repeat one more time, please.
I say when they go collaborative, then I would have to start submitting the G code for their billing.
Yes, sir.
Okay. I got one other question. I got two doctors who see maybe 15 to 20 Medicaid a year. They're going to be pretty much exempt, are they not, from the e-prescribing?
They see Medicaid patients only?
Medicare?
No, they wouldn't be exempt if they have not attested to meaningful use in the year 2012 or the first 6 months of 2013.
Yes, they have. They both attest to meaningful use.
And yes, they would be.
They would be exempt. Okay, good.
However,
because I have a low Medicare patient load. I mean, it's like I said, probably maybe 20 patients a year.
unfortunately, PQRS does not look at Medicare patient volume at this point.
Yeah, as far as meaningful use and the e-prescribing, it does.
So if you
Correct.
see Medicare claims, then you could be subject to a penalty.
All right. Thank you so much, Ben. I apologize. It is 1 o'clock right now, so we have run out of time. We really appreciate all of your questions. We see that a few of you still have questions out there, but we've got your number, or rather we've got your name and your contact information. We'll try and respond to you either via phone or email. And certainly if you think of something here in the next few days and you want to ask him or Relinda a question, her contact information is up here on the screen right now. Thank you again so much for joining us today. We do appreciate you attending our webinar. And again, if you have questions, feel free to contact us. Otherwise, we will see you for next month's webinar. Thank you all so much.